Medicine is the only science that addresses just one part of its problem, just the bio or the disease part, and excludes the psychosocial. Medicine in those terms is by definition non-scientific.
Hi everyone, I'm Kirsten Davidson, your host and creator of my wellness podcast, Mind the Gaps, where we work on surrendering our typical ways of looking at life to step out of our comfort zone and into our growth zone. Welcome to episode number 32. Has medicine lost its mind? In today's conversation, I had the eye-opening experience of sitting down with Dr. Robert C. Smith. Dr. Smith is a University Distinguished Professor of Medicine and Psychiatry Emeritus at Michigan State University. With many publications, awards, and strong grant support, he's been involved in teaching and research in patient-centered communication and primary care mental health since 1985. He and his colleagues defined the first evidence-based patient-centered interview, now published in a popular interviewing textbook, Smith's Patient-Centered Interviewing, an evidence-based method. Dr. Smith's group also identified the first evidence-based method to teach primary care clinicians how to identify and treat mental health and substance use problems. Published as a result was Essentials of Psychiatry in Primary Care, Behavioral Health in the Medical Setting. Educators use both books to teach medical, nursing, and other healthcare students in the USA and abroad. Dr. Smith's newest trade book, Has Medicine Lost Its Mind?, was published most recently by Prometheus Books on March 4th in 2025. Fed up with medicine's resistance to improving training in mental health care, Dr. Smith decided to take the problem to the public. The book addresses the poor state of mental health care, why medicine ignores it, what needs to be done, and how to accomplish this politically. Details are available on his website, www.robertcsmithmd.com. And furthermore, as you probably guessed, today's conversation hones in on this book, discussing the ins and outs of why mental health care needs to be addressed in the medical setting and what we can do about this today. If you like what you hear today, taking a moment to rate and review the podcast episode is always greatly appreciated. We couldn't do this without your support, so thank you so much for tuning in, and I hope you enjoy. So, Dr. Smith, what inspired you to write this book, Has Medicine Lost Its Mind?, and tackle such a critical issue in mental health care?
I've been in the business academics and, developing methods and showing research that supported it to demonstrate how to teach doctors primary care mental health. Right now, they're not taught at all. And medicine knows this. Medicine knows there's a mental health crisis, and this is the cause of it. But medicine's not doing anything about it. So I decided to go to the public. That's why I wrote the book. That's why I'm talking to you. The public is completely unaware of how poor their mental health care is. It's not nearly as good as medical health. I think most people assume they go to the doctor, a mental problem will be cared for just as well as a physical problem. It's not. And that's the problem. And here is the reason for it. And most people are not aware of this. And it's kind of scary for your listeners and viewers. 75% of all mental health care in the U.S. is conducted by primary care doctors and other medical doctors like me. Here's the problem. Nobody trained us to do this. In medical school and in residencies, that's about 15,000 hours it's been counted. Less than 2% of all that time is devoted to mental health care, even though mental health care problems are the most common health condition doctors face. Has medicine lost its mind? That's where the title of the book comes from. How can it do such a crazy thing? And the downside of this is just awful. There are nearly 100 million people in the U.S. with a major mental disorder at any one time. When those diagnoses, and most of them are not recognized or treated effectively, when that happens, the downside is tremendous. Divorces, school failure, job failure, addiction, homelessness, incarceration. Now, I'm not saying we can prevent every one of those, but if doctors knew how to effectively treat 100 million people with a mental disorder, you could prevent an awful lot of this carnage to the U.S. population. Now, those are difficult problems. Deaths also result from doctors' lack of recognition and treatment. There have been over 200,000 deaths in the U.S. since the opioid epidemic began. Every one of these could be prevented. These are all prescribed. These opioids, OxyContin, Vicodin, are all prescribed by doctors like me. We haven't been trained, though, in the use of opioids or in chronic pain, which is why opioids are given. So those are all unnecessary deaths now. We're not talking about just divorce and job loss. We're talking about death. There are, another example, 48,000 suicides per year. Half of these people see their doctor within 2 to 4 weeks of the time they commit suicide. But doctors aren't trained in recognizing, much less doing anything about suicide. And people don't walk in and say, I'm suicidal. You have to know certain skills and be suspicious of where it might exist and to subtly inquire about it. People are embarrassed to talk about it oftentimes. And so doctors simply lack these skills. Half of those suicides potentially, the ones visiting the doctor in the 2 to 4 weeks, could be prevented. But medicine doesn't do this. Now, don't blame your doctor. We haven't been trained. They didn't train us in this. And in fact, you talk to any doctor, they'll tell you what the problem is. Bob, one of them told me the other day, there's no psychiatrist in my town. What am I supposed to do? I'm doing the best I can. And indeed, doctors are doing the best they can. It's not their fault. Another one told me, he said, yeah, there's 3 or 4 psychiatrists in town, but it takes 10, 12 months to get a patient in to see them. They're so busy. And so a point, again, most people don't understand this. Their psychiatry sees no more than 12% of all mental health patients in the U.S. Psychology sees another 12 to 15%. But the remainder, the 75%, are cared for by untrained primary care doctors. Now, the solution, and medicine knows this, and people have been telling about this since the 1960s. The solution is obvious. Train the doctors who provide the care. But medicine doesn't do it. That's why I'm going to the public. Medicine is off the rails right now, and it needs to be corrected.
And you said how you took a training in LA at the Center for Healing Arts in your book, and that was kind of the pivot for you in terms of looking at this issue as an issue. And you said it filled so many gaps in your knowledge. I'm curious what those gaps were. What was it like getting training at that facility versus traditional medical school?
Yeah. Sure. Well, traditional medical school doesn't address anything about doctor-patient relationships or how to communicate. Now, in fairness, they do teach interviewing now. They didn't when I was going through medical school. They do teach interviewing and doctor-patient relationships now, but it's usually just in the first year of medical school and is washed out, 8 or 10 years later by the time they graduate. They don't follow up on it. And so I had none of that. And one of the things that happened in practice is when I got there were all kinds of people with mental health problems. I didn't know what to do with them. And did poorly with them. And I'm not alone in this. I wasn't unique. When I would talk to other doctors, they would say the same thing. I don't know what to do with these people. They keep coming back. I don't know what to do. So I just ordered tests or something. But in any event, I decided over time that this was such a problem that I wanted to do something about it. And I then left practice and I went to the LA Center for the Healing Arts and worked with some wonderful people there where I learned about doctor-patient relationships, caring about people, listening. And I then went on after that. I was about a year there, went to University of Rochester in upstate New York and trained in so-called biopsychosocial medicine. And that was the real awakening for me. That's where I actually learned about interviewing, doctor-patient relationships. I learned about psychiatry, how to diagnose these problems I didn't know what to do with in practice. And I trained there. I was on the faculty there then after that for 3 or 4 years, and then I've been at Michigan State. And it was at Michigan State that I then developed an interest in the fact that we must train primary care doctors in mental health. There were no methods at the time. They were kind of all over the place, and mostly it came from psychiatry. And psychiatry is not familiar with primary care mental health, which is where most people come. And so we developed 2 things. First, we developed a patient-centered interviewing method. In other words, how you interact with a patient in a consistent way to establish good communication and a relationship. You'll be familiar with that in psychotherapy, but doctors aren't taught that. And so we developed a method, but we went beyond that. Once you can identify a method, in other words, what you do from start to end, then you can study it. And we studied it in 2, 3 actually randomized controlled trials and demonstrated not only was it easily learned, but that it improved patient outcomes. Okay, so that was the first thing we did. We got established. All doctors need to know how to interact and establish a relationship. And so we now had this evidence-based method for it. In fact, we have a popular textbook out. It's now going into the 5th edition, which is used across the country and internationally, actually, for training in just this purpose. But the next step then is if you're interviewing somebody right and listening, and remember, I've already told you mental health problems are the most common health condition there is. If you're interviewing them properly, you're going to hear about oftentimes at least, about their mental health problems. Well, doctors aren't trained in that, as we've already heard. So we then developed, and this is again at Michigan State, we developed the first primary care mental health model. Okay, we've now got a model. It's teachable. We then studied that in 2 randomized controlled trials and showed that not only was it easily learned when we would teach it to someone, but that the outcomes from having done that were also improved. So we now had the evidence-based primary care mental health model. Okay, I and many others have worked throughout the years in teaching mental health and communication, doctor-patient relationship to medical students and residents, but it's not taken much hold. As I said, a little bit of interviewing now takes place, but there's still no training in mental health. Less than 2%, I've said, of all training time is devoted to the most common health condition there is. And so that is what I'm trying to correct. Basically, what drove me into all this is I want to prevent primary care doctors from getting into the dilemma I had in practice and in causing the carnage to patients that lack of training results in.
And reading about some of those examples
in your book of that carnage was really interesting, how you were feeling like you lacked the skill, right, to be able to meet them where they were at. And I was reading Bruce Lipton's Biology of Belief earlier this summer, and I wrote down a quote for this episode. He'd said, "Today's physicists have completely failed to inform us of the mental nature of the universe." What do you think about that quote?
That gets into philosophy, doesn't it?
Yes, definitely.
Yes, I think it's a correct comment as people wrestle continuously with what is the mind? Is it just a brain function, or is it something beyond that?
Kind of leads into your perspective on the mind-body split. So I was reading that section of your book, The Historical Mind-Body Split in Medicine. And if you could share with listeners how this has created such a significant gap in mental health treatment, because when I was reading about this, I appreciated how your storytelling on it goes really, really, really far back, and it sheds some light on things I hadn't heard about before.
Yeah, no, we'll backtrack just a second as a lead up to that.
Sure.
Is why is medicine doing such a crazy thing as to not train its doctors in the most common health condition they'll see? Has medicine lost its mind? Okay, but ask that question more seriously. Has medicine lost its mind? It did. Yes, it has. And that's why we have the problem. It's called the mind-body split you refer to. Medicine began back in the 5th century BC, over 2 millennia ago, with Hippocrates. And up until the scientific revolution in the 16th and 17th centuries, people always saw the mind and the body going together. There was no mind-body split. And doctors would see mental health patients just like they would see physical disease patients. But come the 16th, 17th centuries, the church, which had run everything in society, including science, art, everything else, up until that time, and this is what the revolution was about. Science was getting anxious, and they were starting to realize there was more going on than what the church was addressing, basically. And so what happened at that time was that the church was being pressured, but so all-powerful, and science got permission. Now we're talking about medicine as a science. Medicine got permission from the church to begin addressing the human body. And where did they address that? The basic science back then was human anatomy. Well, you have to dissect the human body if you're going to understand the human body. Up until that time, it had been prohibited by the church. So doctors and students dissected cows, pigs, goats, and the like. And from that, believed that's what humans were like, which is, we know, is completely erroneous. So in 1537, Pope Clement said, okay, doctors and medical educators, you can dissect the human body, but one proviso: the head must be removed from the body, decapitated, and turned over to church authorities for proper burial before the dissection can begin. That started the mind-body split. The church was to keep the head. That's where the mind, the soul, and the spirit existed. That was the church's alone. Medicine got the body from the neck down. And that started it. And dramatic changes evolved in anatomy back then. It spread then into chemistry and physiology and so on. And then in the 17th century, everybody's heard of Descartes, Locke, and Hobbes. These people provided the greatest impetus for the mind-body split, and they provided the philosophical basis for continuing this separation of the mind and the body. That then continued it permeated into clinical medicine in the 18th century, and then in the last century, the 1900s, it was dramatically effective. Our life survival doubled from age 40 in 1900 to nearly 80 by the end of the century. This is a dramatic change. This was highly effective. And that has to be remembered. Much of what I talk about often sounds like it's critical of it. It's not. It has been highly effective. It's what I was trained in, and it's what doctors today are still trained in. And we do great jobs with MRIs, heart transplants, kidney transplants, genetic analyses, and so on. It works. It's great. The problem came about, and this is why this mind-body split is now working a hardship on patients, because the patients have changed. They're no longer the acute surgical and infection problems that were happening 100 years ago today. Now we've got mental health problems because people are living longer. Mental health problems have surfaced to become the most common health conditions. They're always there, but now people are living longer and they happen. But another thing has happened. Chronic physical diseases, medicine's forte, have emerged. And it's obvious how splitting the mind away from the body in medical education, as I've told you, no more than 2% of education in it, it's obvious how that leads to problems with mental health. And that's the cause of the mental health crisis right there. But it's further difficult for physical disease, medicine's forte. If you split off, as medicine does, the psychological and social, it harms physical diseases. That's a little harder for people to understand. But how does it do that? Let me give you just one example. Most physical diseases today are caused by psychosocially based lifestyle features. Drinking, smoking, eating too much, not exercising, stress. These are all psychosocial factors that medicine ignores in training. Mm-hmm. Now, of course, a doctor will say, quit smoking or lose weight, but that doesn't work. There are complex skills required to get people to change habits that they don't really want to change. And so medicine is basically ignoring all of that. Okay, so what's the downside of that? These 80% of all heart attacks, strokes, diabetes can be completely prevented if we prevented these lifestyle factors. Medicine doesn't do that. Medicine instead waits for the disease to happen and then treats it.
Right.
And so think of the U.S. healthcare expenditures. It's now $5 trillion every year. What would happen? Think of the savings that come from preventing 80% of all heart attacks, strokes, and diabetes. And you can also prevent 40% of all cancers. You would save $2 trillion or more every year by just preventing these. But medicine doesn't do that because it excludes psychological, social factors as well as mental health factors. And so medicine doesn't do it. And this is where I say medicine has gone off the rails. It knows about this. It does nothing, does next to nothing about it. Now, of course, medicine is addressing some of these things, but medicine spends less than 3% of its total healthcare expenditures on prevention. How ineffective has it been? 15% of the population were obese in 1990. It's now 50%. That's a colossal failure in prevention. And the downsides are not just economic savings to the public and the taxpayers, but people with all of these diseases suffer greatly. They die earlier. They become incapacitated. And so medicine is simply ignoring that. They could prevent all of that from happening as well as save money.
Yeah. You mentioned too how doctors have, when they are prescribing medication for mental health, it's often wrong. And if it is correct, it's often the dose is not correct. And you've said in your book that it fails 90% of the time.
That's right. But let me be clear again. I've said this already, but it's not the doctor's fault. Mm-hmm. They are doing the best they can do. Medicine has left us high and dry when this most common health condition in practice comes into our offices. Medicine let us down. But when we try, it's usually ineffective. And that's what you just said. The diagnoses are usually wrong. if they happen to get the right diagnosis, the treatment is usually insufficient. I mean, for example, the dose will be too low. Treating somebody with depression requires gradual increase of the dose, which means follow-up visits over time. Doctors don't follow them up. And prescribed antidepressants, for example, most people have stopped them after 1 month. They're not even taking them, and that's hardly time for it to begin to work.
Mm-hmm. Yeah, I like how you focus on how it's not the doctor's fault. It's not the individual's fault. It speaks to the more systemic problem, which is what you're trying to address. And I like how in your book you included some quotes that really share or demonstrate what doctors, including yourself, looked at when it came to mental health, right? And comments like, well, I'm not going to go there with them. That's mushy-feely. That's not really my job. That's out of my scope. I'm not supposed to explore that. Feeling like it's not their role. Traditionally, it hasn't been their role, right?
No, it's not. And they're not taught. Modern doctors are like a fish in water. The fish knows only water. Doctors know only physical disease. Many of them, I mean, they will often dismiss psychological problems. That's not my problem. I haven't been trained in that. They should go see the psychiatrist, they'll say, or a psychologist. Well, I've already told you there's not near enough of them. And so they don't do that. They come to us instead. And it just goes on from there. There's no, they simply don't see it as they're in their avenue. And there's a so-called culture of medicine that goes with this. And it very favorably looks at psychological and social issues. And this isn't just mental health we're talking about. It's any psychological and social issues. It's the ability to interact with the patient in an effective way to establish a relationship, independent of whether they've got a mental disorder or not. So it's all psychosocial stuff. And so medicine ignores that. And then in this culture of medicine, that's accepted. And that's part of what you're saying. That's not my job. That's not what I do. But this culture of medicine is more powerful even than that. Not only do they not teach about psychosocial issues, doctors, students, and residents learn to not only dismiss them, but disdain them. Don't handle that touchy-feely stuff. We're not about that. Don't get too close to the patient. It will destroy your objectivity, they'll say. And there are also even worse remarks. Somebody will say, well, maybe this patient should see a psychiatrist. The psychiatrists are across the street, I think they're as crazy as their patients sometimes. There are negative statements like this that come out. And so this negative culture, and part of that culture then is medicine is autonomous. Medicine was highly effective, as I said, in the last century. And, came to be quite proud of itself, justifiably so. And we know how to do things and so on. And it's an insular profession. It runs itself. It has no societal input. Society may tell you we don't want test tube babies or we don't want AI running our lives. Society doesn't tell you anything about what medicine should do. Medicine insular, it's protected. And so what has happened is this is why I said it's gone off the rails. It's moving along on its own, but on its own, it's no longer working. It worked famously in the last century, but society needs to get involved and tell medicine what to do. That's why I'm writing this book and talking about this stuff. Hannah Arendt, the famous philosopher and historian, weighed in on this. She said, basically, the question is, should the sciences be run by society? Should they be responsive to society, or should they go on their own? Medicine is a case in point of what happens when it's allowed to go on its own. It's gone off the rails as we're talking. And that was her point, is that society must determine what direction any science takes. And again, artificial intelligence, test tube babies, we've weighed in on that. And so that's the problem. And this culture of medicine then is what needs correction, and it needs supervision from the outside, from a societal level down.
Yeah, absolutely. And I remember you saying in our last chat that people should be getting angry about this so that they can then influence
Exactly.
policymakers, and that can
Yeah.
eventually spark some change. So you outline in your book a roadmap for reform. I'd love to hear
Yeah.
what the top priorities are for transforming the mental
Yeah.
health care system.
Yeah. I mean, the top priority is training doctors in not just mental health, but all psychosocial material. And medicine already has this model. It's described in the 1970s. It's called the biopsychosocial model.
Mm-hmm.
The bio is the disease parts, but it links the psychological and social, and they all go together. Now, medicine has embraced this in its writings. Almost all mission statements will have biopsychosocial in them, but it's only lip service because they still don't teach it. It's still just 2% like it was over 100 years ago. It's still just 2% devoted to psychosocial and mental health issues, even though they're the most common problems. I won't go into that again. And so it's there, and that's what it basically, it needs a biopsychosocial theoretical focus. Biopsychosocial is simply medicine's systems theory-based application in medicine. Systems theory, all sciences come about the 1900s and so on up to the present, have begun to embrace a systems approach, which means that you look at all parts of a problem, not just one part. Medicine is the only science, physics, biology, ecology, so on down the line. All other sciences have embraced the systems approach. Medicine is the only one that addresses just one part of its problem, just the bio or the disease part, and excludes the psychosocial. It is then in those terms, and remembering all other sciences espouse this, medicine in those terms is by definition non-scientific. And that is a terrible condemnation.
Mm-hmm.
Because we in medicine all believe we're quite scientific. And in fact, we are when it comes to physical disease. But at a broader conceptual level, medicine has not matured. Physics, just as an example, was equally, it's what they call reductionistic, when you focus on just one part of a problem rather than the systems approach of focusing on all parts of the problem. All sciences back in the 16th, 17th century scientific revolution were reductionistic, focused just on a few parts. Newtonian physics, which everybody has heard of, comes out of that, was highly effective, just like medicine's physical disease focus was highly effective. But physics transitioned with Einstein, Planck, general relativity theories, and quantum theories at the turn of the century to a systems-based approach. It didn't lose anything that Newtonian physics had provided. It simply complemented it. And that's where medicine has conceptually arrested. It has come up, it's done well with what it's done with its physical approach, but it hasn't conceptually learned the systems approach of integrating the other parts of the patient. I mean, who in fact is the centerpiece of the science of medicine? It's the patient, isn't it?
Mm-hmm.
Of course. Medicine doesn't address the patient. That's the psychological and social part. Medicine addresses the disease that the patient has, but it does not address the patient. And so that is not only has all these terrible complications I've talked about, but it is scientifically untenable. Medicine has conceptually failed, and this is why the public now must get involved and insist on change. You ask, how to do this? What do you do? First, the public has to be informed, and most of the public does not know what we're talking about. Mm-hmm. This is why they need to hear this stuff. They need to become angry and furious why their relative committed suicide when they seen the doctor 3 days before, why their son overdosed on OxyContin, why they got divorced and they were really just depressed and needed to be treated. People need to get angry about medicine's maltreatment of them.
Yeah. That it becomes a human rights issue at that point.
I mean, get this. Thomas Insel is the former director of the National Institute of Mental Health. It's the biggest mental health operation in the world. Who would know more about mental health than Thomas Insel? In his book, he says, modern mental health care is so poor as to represent a human rights crisis. People need to listen to him. He's right. It's a mess. And so the question then becomes, what do you do? Okay, the public gets angry. What I think needs to happen, and medical education is the first place to focus on change. It's that 4 years of medical school, 3 or 5 years of residency, that, some 7-10 years in there. That's where doctors are brainwashed in this mind-body split. Mm-hmm. And you've got to interrupt that. We can no longer operate out of that. And that's where it has to start. And so what the politicians will do, in my opinion, people will be angry. The politicians now want to do something. Well, what do? They set up a federal commission that investigates all medical schools and residencies to see, A, how scientific they are, and B, how well they're treating people with mental disorders, training people for people with mental disorders and chronic physical diseases. Well, you've already heard. They're going to be non-scientific. They're botching mental health care completely, and they're just as bad with chronic physical disease care. That will then lead this committee, this federal commission, will then make recommendations of this sort I'm saying. Medicine, you need to transition to a more scientific approach that integrates psychological and social factors with physical disease. And that is what will start this off. Now, much more needs to happen, but that should be the starting point. Once that happens, leaders will start coming out of medicine. See, leaders in medicine today are all products of this brainwashing. Many of them do, in fact, understand that there's a mental health problem. It's not that medical people don't understand it, but it's not in their psyche, it's not in their soul to work with it. They still are primarily oriented to physical diseases. Mm-hmm. And so this is the first step in what needs to happen. And you may ask, how do you get the public angry? How does this work? Well, there's models for this. Ralph Nader wrote Unsafe at Any Speed. And this is kind of an analog to what I'm doing. Has Medicine Lost Its Mind? Is designed to anger the public and induce change. Okay, Ralph Nader wrote Unsafe at Any Speed. Automobiles at that time, auto industry knew seatbelts worked and they had them, but they weren't using them. They weren't putting them in cars because they were afraid people wouldn't use them and it would cost them money. They'd lose money. And so they didn't do it. And there were a host of other safety problems. When you put the gear shift forward, it often went backwards. And so on. And they knew about this. They just didn't correct them because it would cost too much money. And so Nader's book comes out, how unsafe automobiles are and where that institution or industry is not doing anything about it. Just like medicine is not doing anything about all these problems I'm talking about. They went to the public got its politicians going, and that led to the formation of the Motor Vehicle Safety Act, which is why you have seatbelts in your car and a host of other protections today. Mm-hmm. Another example where a book angers the public and the politicians do something as a result. Rachel Carson wrote Silent Spring. At that time, the chemical industry was polluting everything. There was even DDT in our drinking water, if you can believe that. Okay, they knew it. They weren't cleaning up the messes they left. They knew it was harmful, but they didn't know anything about it because they didn't want to lose money. Okay? Rachel Carson's book comes out, inflames the public. Politicians get in gear. That led to the Environmental Protection Act that we have today. And that's why you don't drink DDT in your water, and you have a ton of other protections. Has medicine lost its mind? We'll do the same thing. Anger the public, get politicians in gear, and then they will have a federal commission conduct an investigation of all medical schools.
Yeah, and as it should, as people read work like yours, it should evoke that feeling of anger, injustice, and then desire for change, a desire for more. And I think how, it's a radical shift. Obviously not in my sphere because I'm used to focusing on the mind and the body stuff that it's like, okay, that would be amazing if we could integrate these both into one practice.
Exactly.
And that's exactly what you're talking about. But I think I'm curious your thoughts on individuals who, and I think this is a large majority of individuals who view the influence of the mind on the body and the influence of the body on the mind as being non-scientific, as being kind of spiritual almost, or woo-woo, or not scientific. Meanwhile, you're saying the lack of integration between the two is actually not scientific.
That's exactly right. I mean, we've talked about medicine being, and again, reductionistic means focusing on just one part of the problem. Holistic or systems view means focusing on all parts of the product. Mm-hmm. Many people have made the mistake of going in the other direction. Medicine is reductionistic by focusing just on the physical, but you can be equally reductionistic by focusing just on the psychological or just on the social. Mm-hmm. It requires instead an integration of the mind with the body and how all of this interacts. It's a remarkable process, and it's fantastically interesting from a scientific standpoint. But people then spin off in either direction, and neither will be effective for the reasons we've talked about. They must be integrated.
Mm-hmm. And you say that so much needs to happen, and you're outlining that roadmap of the steps of things that would need to happen. But what is it that policymakers and healthcare leaders could do right now, today, to begin closing that gap between mental and physical healthcare?
Yeah, integrating this biopsychosocial, or just integrating psychological, social, and physical diseasing. Medicine could do it today. They could start teaching. For example, teaching interviewing and doctor-patient relationship, not just in the first year of medical school, but in every year and in every year of residency. You could start teaching mental health in every year and in every year of medical school and every year of residency. And so now, for people listening to this that are angry about this, my website, robertcsmithmd.com. And don't forget the MD. There are too many Smiths. Okay, so it's robertcsmithmd.com. And you will see on the very landing page something that says Act Now. There are a list of email addresses to key people, from the president to the surgeon general to the National Academy of Medicine to your congressperson and your senator. There is a short paragraph recommending what you and I have just talked about here, advising of the seriousness of the mental health problem and that we need a federal investigation of all medical schools. All you do, paste that little paragraph into the emails and send it. This is the way you start activating and informing the politicians. They also need to be informed of this massive problem, and most of them are not aware of it. People you will find are addressing the mental health problem. People are well-intended. These are not bad people. This is a massive conceptual change that needs to happen. No, there are no bad actors in this. the people are doing the best they can, but they need to think more broadly, out of the box, as it were. And they're doing things today. I mean, they're trying to improve, for example, payment of primary care doctors to see mental health patients, so it's easier to pay. That the pay is terrible for them. But again, you're still left with an untrained primary care doctor. And so medicine is well-intentioned, but right now is simply tinkering at the margins of the mental health problem. They need to go to the conceptual basis that we've talked about and change. Then all these other things will fall together.
Mm-hmm. What a brilliant resource to have on your website for people to be able to start doing that, right? To cause an uproar, to ignite change, to have the policymakers hear the same messages again and again and again till something bigger happens from that. Yeah. In your patient-centered interviewing model, I'm curious if you could share with listeners what some of the questions are that get asked that is a radical shift from what normally gets asked, or maybe what doesn't even get asked.
Sure. I mean, one of the basic features is and these skills apply outside of medicine too. They're simply basic interpersonal skills. Mm-hmm. But instead of walking in and saying, somebody will say has a headache, instead of walking in and say, well, where's the pain? How long you had it? What medicine do you take for it? Have you had it before? Do you have any throwing up with it? These are all questions doctors want to know about the physical aspects of that. They're trying to figure out if it's a brain tumor, is it migraine, is it tension headache? They're trying to figure that out immediately. Mm-hmm. So instead of doing that, the doctor says, tell me more about the headache. And the guy might go on to say, well, it's been there a couple of days. He might answer some of these questions for you without being prompted. And might go on to say, my wife said I should be thinking about the work I'm doing. You don't go back and say, well, did you take aspirin for it, or have you taken anything for it? You said, listen, your wife said what? What about your work? Well, since this headache began, there's been a new boss at work. And so on, you can see where this is going. So instead of listening to and interrupting to focus just on the physical, people want to tell about the broad context, the psychological and social aspects of the headache. Mm-hmm. And so you go on and find out maybe this guy's having trouble at the job, and he's got a tension headache as a result. And so, but you find that out. You then maybe talk to him about the job, or have him see a counselor about problems on the job, and instead of just giving Vicodin or OxyContin for the headache. And so it's a radically different outcome. You hear the psychological and the social aspects of the problem. Mm-hmm. Then, I mean, the key part, and you know this as a psychotherapist, but is to get to emotion. So, how does that make you feel that your boss seems to disrespect you? They give you an emotion, hurt, down, angry, whatever it might be. And you then draw that out some more. So tell me more about that. Yeah. Reminds me of my father. He used to dismiss me when I said things, and so it goes on and on. And the discussion is not a psychotherapeutic discussion. It takes place in 2 or 3 minutes. It's all that happens. And so you then need to be empathic with this emotion. And we have a mnemonic we use for it. It's called NURS, NURS. You name the emotion. So you were hurt. You understand it. I understand that. R, respect. You've been through a lot with this guy. S, support. Let's see what you and I can do working on this together. Now, you don't use all 4 of those at once, but you'd spring them throughout the conversation. And this is highly effective. It's addressing these psychosocial aspects, then getting down to the emotion and supporting it empathically. This is where the relationship occurs. Mm-hmm. And most doctors don't know that. They don't do it. And that's not their fault. These are not natural things to do. People have been raised to ask questions, not to listen. All of us, we're raised since we're 5 years old, not to talk about emotions. Yet, you have to talk about emotions to establish a relationship. And you have to have a relationship to be effective in treating not just mental diseases, but physical diseases.
Mm-hmm.
But medicine doesn't do that.
Mm-hmm. In your model, you're prompting the physician to give up power and control as they've been taught, and giving power and control, some of it, to the patient. Because like you're saying, what is all this healthcare for? Well, it's for the patient, and allowing them to, I use the phrase, people will tell on themselves. So if you let them talk long enough, they'll tell on themselves. They'll reveal what's going on.
That's right. Yeah. And people, and let me say something. People, your listeners and viewers may think, well, that's all great, Bob, but that's just going to take me forever to do that.
Mm-hmm.
It doesn't take any more time. It has been studied. It takes no more time. And in fact, it probably saves time to do that.
Wow.
And so disabuse yourself of the idea this is going to take longer. Now, it takes a long time to learn it. These are complex skills that need to be learned. It takes a while learning, and this is what should happen in medical school. And this is why you can't pick this up and read a book and all of a sudden, do it. Mm-hmm. Reading a book helps, I must say, in practicing, but this requires training. Mm-hmm. And so it just requires experiential training, is the best way to say it. You have to have somebody supervising you that knows what they're doing and how you're responding to it.
Yeah. I think it's important that you distinguish when you say that that nurse model, that is not a psychotherapeutic conversation, because in saying that, you might be alleviating the physician who's listening to this feeling like, well, do I have to conduct a psychotherapy session? I don't have the tools for that, nor do I want to do that. So in using that model, then I would assume they're able to feel confident saying, here are some referrals for you to get additional care, rather than...
That's exactly right.
Yeah.
We are not advocating that all doctors become psychologists or psychiatrists. What we are saying is that doctors should be able to provide preliminary treatment for most people with the common problems, which are depression, anxiety, and substance abuse. Mm-hmm. Most doctors should be able to recognize and effectively treat the easy cases of that. The difficult ones, in other words, where their treatment doesn't work, should be referred out to psychology and psychiatry. And just a comment on psychology and other skilled therapists. This is a tremendously useful resource that is underused in medicine today. And one of the reasons for that is that psychology has never been incorporated within medicine. Psychology is a different discipline. And one of the things that will happen in this new world we were talking about, where we're starting to train everybody, what the politicians will insist on, will be to bring psychology much more closely into medicine. Now, instead of overwhelming people in psychology with patient after patient, doctors will have worked with someone and will have ascertained that it's beyond their capacity, and will also know what they're looking for, and will maybe be able then to work with the psychologist or other therapist by, say, giving medications. In other words, you will keep the mind-body connection because the doctor will still work with the physical diseases and things and the medications. Mm-hmm. Many family medicine residencies, I'm in internal medicine, we don't do this, but many family medicine residencies have psychologists and sometimes even psychiatrists as part of their faculty. Mm-hmm. And family medicine is another dimension of primary care. And so they're actually right in the clinics, and they conduct some of this biopsychosocial interviewing, mental health care that we're talking about. Mm-hmm. and so that is the logistically. Another thing that I think can happen is that psychologists right now cannot prescribe medications. And but what people don't recognize is psychologists and therapists provide treatment, say for depression, which is just as effective as medications. And they should do that. The ideal is to use both therapy and medications. They do better than either one alone. And that's where you would work with your referring doctor. Now, psychologists and the APA, American Psychological Association, has recommended this quite some time ago, is that psychologists take postdoctoral training in medical settings. And this prepares them even more so for working in medical settings. And again, most mental health problems are in medical settings. It's primary care mental health. It's not this the people that end up in psychotherapy or with the patients with schizophrenia. Most of it is more garden variety stuff: depression, anxiety, substance abuse. And so that prepares psychology even more so for that. I worked with I think the first program of this is in Flint, Michigan. A fantastic program. And psychologists like it, the doctors like it, everybody.
Mm-hmm. Yeah, I like how you're suggesting not only should medical doctors be more aware of the biopsychosocial, right, but the psychologists, psychiatrists, psychotherapists be more aware of the
Of the medical,
biopsychosocial, yeah, of the
yeah,
medical,
yeah.
because that would help marry the two and create more of that holistic model and even just communication between people like myself and people like yourself, right? Being able
Exactly.
to have conversations about the same client, the same patient, and merge our knowledge so that they're getting the best quality of
That,
care possible.
that's right. It joins the mind and the body. And
Mm-hmm.
right now, that's what can happen. But doctors need to recognize that there is a problem in the first place simply to engage a psychologist.
Mm-hmm.
And psychology, in my mind, also is often a preferable direction to refer rather than to psychiatry. Psychiatry anymore sees people mainly just for drug management. And if you need somebody where you're having trouble with drugs, I guess that's where you would go. But psychology gives a broader outlook. Most psychology and other therapists know if somebody needs medication, but they also do the therapy, and they would know then if they needed to be referred to psychiatry or whether they could work with the primary care doc.
Mm-hmm.
And so the psychology is an overlooked aspect, I think, of medicine.
Yeah, and I believe you said in your book that most psychiatrists do not practice psychotherapy in their work, that
No.
it's mostly related to prescribing
Yeah.
rather than providing that
Yeah.
one-to-one treatment that takes longer.
Yeah, I think the figures are like less than 10% of psychiatrists anymore provide psychotherapy, and the
Yeah.
rest of them are doing, unfortunately, in my opinion, at least 10 to 15-minute visits for medication management,
Mm-hmm.
which is very useful, but psychiatry could go beyond that.
Mm-hmm. I'm curious also when you talk about context, right? And how when you have that deeper conversation with the client, with the patient, you gain context of what's going on in their life.
Exactly.
What do you notice happens for the patient when they're given space to provide context?
Oh, they like it. I mean, this is where they say, this is the first time anybody listened to me.
Yeah.
And they bring out things that help in solving the problem. It might be somebody lost their Medicaid,
Mm-hmm.
or, as is now going to be happening, losing their affordable care, or they can no longer afford it to the ACA.
Mm-hmm.
And the doctor needs to know that context. You can't prescribe one of these expensive $1,300 a month weight loss drugs to somebody that can't afford to put food on the table. And so you need to know the context of what's going on, the psychological context. I mean, are they depressed? That's context. And for doctors focused just on physical disease, they need to know this because it determines what the treatment is. And again, not just mental treatment, but physical disease treatment. People, I mean, one of the common problems in medicine today is, and you'll see it in the literature all the time, and doctors are puzzling about this. They don't understand why it's happening. It's readmissions to the hospital. They'll bring somebody in with difficult diabetes, difficult heart failure, difficult emphysema, whatever it may be, and they're disabled to some extent, or they wouldn't even be in the hospital. Okay, they get them fixed up, right medications, all the physical disease stuff is done, okay? And the person looks good, they send them home, and they're back in 3 weeks. And doctors, why is that? I don't know. Okay, it's what they call tune them up. They'll then start them back on all the same medications again. Same thing all over again. They're back in 3 weeks. They get hospitalized for 3 or 4 days. They're out and they're back in 3 or 4 weeks. This just keeps going on. It's a terrible cost problem for hospitals. Is this recurrent admissions? Well, what's happening is these people are depressed or anxious, and it is not being recognized or treated. Once you recognize that this woman with refractory heart failure is depressed, and if she goes home and doesn't take her, she's so depressed she doesn't take her medications. She eats salt because she likes it in her diet, and she was in a heart failure again, and she comes back. Once you treat that and recognize it, the recurrent admissions go away. And it's been demonstrated. There are statistics on this. It's this so-called comorbid or co-occurring mental disorders with a physical disease problem. And it afflicts something like 17% of all people with chronic physical disease. It's some 30 million people. This isn't a minor problem. And it's been demonstrated that no more than 12% of all these people get any psychological treatment. And it's not surprising because these are physical disease problems being cared for by physically disease-trained doctors who don't recognize the depression and therefore don't treat it. And so these patients just keep being readmitted over and over. And there are other kinds of recurrent problems like that, but this is just one example. It has been demonstrated in a careful actuarial analysis that if these co-occurring mental health problems with a physical disease problem were treated, it would save, and this is save, $26 to $48 billion every year. That's more than the National Institute of Health budget.
Wow.
I mean, these are big numbers, but medicine doesn't do this. And that's nothing compared to the $2 trillion you can save by prevention.
And it's a win. It's not just a win-win. It's a win-win-win. And I say it 3 times because we end up saving so much in general, right, as a society. The doctors, it sounds like, would feel more competent in what they're doing. And then the patients are feeling cared for and getting the treatment they want.
Exactly. I mean, it is. It's win-win-win.
And with that in mind, I'm curious then, just to wrap up, Bob, what gives you the most hope that meaningful reform in mental health care is achievable?
Yeah, a book like I've written, Has Medicine Lost Its Mind, can anger the public, get the politicians going. And the hope in that is Ralph Nader's Unsafe at Any Speed, Rachel Carson. But there have been other movements in the public. The Vietnam War was stopped by an angry public. The women's rights movement, the civil rights movement. These are all examples of an angry public demanding politicians do something. It works. It works. The linchpin is getting the public informed and justifiably angry to do something about this. Their politicians will act. And when they know how obvious this problem is and how resistant medicine is to changing it and doing anything about it, they'll act. That gives me hope.
Me too. It's exciting that more light's being shed on this, especially from someone like yourself, Bob, who's worked in the field. Who better to whistleblow than someone who is a physician themselves? So thank you for the work that you do, and thank you for being here.
Well, thanks for having me, and thanks to you for all the work you and others are doing in airing this problem. You're a crucial part of it.
Thank you.
Thank you so much for listening. If you're enjoying the podcast, I invite you to participate in a Growth Zone Challenge. I invite you to take a moment, a second, a gap in your day right now and share this episode with 2 other people. Thank you for minding the gaps with me. I'll see you next time on the journey out of our comfort zones and into our growth zones.